Dr. Mac.
Yes, ma'am. How are you?
It's Friday again. I'm doing fine. You know, this is my favorite day of the week.
Oh, yeah. It's fast becoming mine as well.
I'm trying to tell you, especially with these weeks rolling by as quickly as they have been, and everybody just seems so busy, and we have a lot going on in our lives. I tell you that the weekend is a reprieve. We need that.
Oh, yeah, without a doubt.
Yeah, without a doubt. So I want to thank everybody and welcome everybody to the Network Live here Fridays at 4 p.m. I am April Garner, the network founder, and of course, my partner in crime, Dr. Winston D. McIver Jr., primary physician and owner of Waccamaw Primary Care in Conway, South Carolina. And of course, this is our 27th week of COVID-19 updates. And we started a couple of weeks ago with a special segment called Medical Minutes, where we're going to feature some other medical minutes because we want y'all to stay healthy while y'all trying to deal with all this stuff that's going on. Yes. And none other than Dr. McIver to give us all of these medical updates. I just want to say hello to our guests who are now streaming in. And of course, can't go any further without mentioning the Emmanuel 9 Memorial Foundation as our destination for our live stream down in Charleston, South Carolina. Thank you so much if you're joining us from the Emmanuel 9 Memorial Facebook page. And then also JD Spain Sr., thank you for tuning in and being a supporter of the Network Live all the way from, I believe, Arlington, Virginia. Yeah, he's up there doing big things and just making it happen in that area. And he's a homeboy, of course, so he comes home and gives a special shout out when he does and keeps us up with us. So thank you. Reese Nesmith, of course, we know her as Tyrese. Officer Knox, exactly. Thank you for tuning in, and none other than the icon, your mother, Marjorie McIver. She's joined. She said we both look very good today.
Thank you, Mama.
Yeah, thank you, Miss McIver. We really do appreciate you. For anyone else who's tuning in, we have a very special show today. We're going to be talking, of course, about COVID-19 and giving you some updates. Dr. McIver is going to give us his weekly stats, and then we'll go over some graphs as we always do. But this month is Breast Cancer Awareness Month. The month of October is Breast Cancer Awareness Month. That's why I'm wearing pink. And we have a very special guest who is going to kick off a little series that we came up with. We're calling it the Yes, I'm a Survivor discussion. And so Ty Davis Grissett is joining us a little bit later on to talk about her story of breast cancer survival. And also she is a medical practitioner. So, she's in the medical field and she can share insights as well. So it's going to be a really good discussion today with both Dr. Mac and with our special guest. And I just hope that you all will share the live stream on your timelines on Facebook. Make sure that you invite all of the women and the men who are special in your lives, because as we learned in last week's segment, even men are susceptible to breast cancer. And so we definitely want everyone to get this important information. I shared with you all last week as well that I had my mammogram, and I'm, blessed to say that my results came back that I have a normal mammogram. So, God spared that from me one more time. And I really do appreciate that. That's grace and mercy. So, it's very humbling to have our special guest here today to listen to her experience. And over the next week or two, we will have some other special guests who will talk about their stories as well. So thank you, Celia Crosland, for tuning in. We really appreciate you and your support of the network as well. Thank you so much. She's a wonderful person and also a proud business owner who I've supported as well. So thank you. So Dr. Mac, I know you want to get into the stats and then we'll get into the slides. So if you will, just take it away.
Okay. So for people that are new to the show, typically what we do is we give a week-to-week update on cases, deaths, and recovery as well. So starting off worldwide, over the last 7 days, the number of cases of COVID-19 worldwide have gone from 32.5 million to 34.5 million. The number of deaths have gone from 990,000 to over 1 million deaths worldwide. In the United States, the number of cases of COVID-19 have gone from 7.2 million to 7.3 million, and the number of deaths have gone from right around 207,000 to right around 212,000. In South Carolina specifically, the number of cases over the last week have gone from 142,000 to around 149,000. And in South Carolina, the number of deaths have gone from a little over 3,200 to right at 3,400 deaths. Specifically in Horry County, we reached a milestone of having over 10,000 cases. Last week, it was a little over 9,900. We're at 10,000 right now. And the number of deaths have gone from 185 to 186 deaths. Georgetown County, the number of cases have gone from 1,756 to 1,776. So that's about 20 more cases. And the number of deaths in Georgetown County have gone from 36 to 42. Marion County, the number of cases have gone from 848 confirmed cases to 887. And the number of deaths in Marion County over the last week have gone from 24 to 27. Now, looking at the first slide that we have, which basically is a graph of the United States. If we see the case map here, again, these numbers were as of last night. And if we see that the curve is kind of doing a downward kind of trend compared to July and August. However, it does appear to be going up just ever so slightly. The number of cases have over the last 14 days have gone up about 8% in the United States, whereas the number of deaths have gone down around 16%. Now, the cases are an interesting thing, and I'll talk about that throughout the presentation about the cases. Those cases, of course, are dependent on the number of people that are tested. And as we know, compared to June, July, and August, people are not being tested at the rate, the frequency with which now they aren't being tested at the rate and frequency with which they were being tested in June, July, and August. So in other words, we aren't doing as many tests. So the number of cases can be somewhat misleading when you don't have as many cases as a comparator. However, time will tell on that, and we'll kind of see. Hopefully, as we get further and further into cold, flu, pneumonia season, the number of tests will start to increase. The next slide looks at new case reports. Again, similar to the first slide, where it just basically shows the peaks and troughs that we're seeing here. In September, right after the early September, the numbers had gone down on new cases, but they're starting to go up some. And we do see that based off what's going on with the weather, the fact that we're going to have likely more cases happen, whether or not there's going to be more deaths, we'll have to see about that. But the numbers are still going up on this graph in the United States specifically. So just kind of watching that average overall. Okay, next slide. We're talking about reported deaths in the United States. As we see, April, May, and June, a lot of the metropolitan cities were hit really hard. New York, New Jersey, Louisiana, Illinois, and that had a huge peak there. And we saw the numbers starting to come down. Then they went back up again, and now it looks like it's starting to trend back downward. We did have a little bump several weeks ago in the number of deaths, but it does appear that this graph is coming down. But again, we'll just have to kind of see what these numbers will sort out as the coming weeks and months approach, getting more into cold and flu season. Next slide. Looking at where the cases are higher and staying high, we've got some states where they're definitely in the Midwest where North Dakota, South Dakota, Dakotas are going up. Some people attribute that to the Sturgis bike rally, which had over 250,000 people there. Certainly Wisconsin, Utah, and those states where we see the numbers are higher and staying higher. South Carolina, over to the far right, where the new cases are high, but they appear to be going down some. So higher than what we would expect to see in South Carolina, but it appears that it may be going down some. But again, only time will tell on these statistics on the new cases, because a lot of that has to do with the actual numbers of people that are being tested as well. So just wanted to show you this as a comparator where it's really high, and in South Carolina specifically. Next slide. So talking about South Carolina, we're kind of seeing The graph here, certainly, as in a lot of other places, July and August, South Carolina was hit really hard with the new cases. Over the last 14 days, the number of cases appear to be going down about 37%. The number of deaths about 34%. Again, we're not testing as much as we were in times past. So is this a factor of the actual numbers going down, or is it just a factor of not testing as much as we did before? So we'll see. More time will tell, but I do want to be fair and balanced about all of this and want you to see what's actually happening. Next slide. This is the new reported deaths in South Carolina. We did have a huge spike around the end of July, 1st of August. We see the number of deaths do appear to be going down. That's a very important stat there. As I showed a couple of weeks ago, where the hospitalizations were going down as well. But again, as we get into cold and flu season, we'll kind of see where these numbers actually are. Okay. Okay. So pull off. Okay, great. So what are we saying? We're saying that the numbers appear to be coming down some. All physicians will say this with caution, though, because we would like to see more testing being done. I was actually just contacted by a source with DHEC who actually has some tests. So we may be having a community test around here really soon. I just got to secure a few other things, but the state reached out to me as a point person for some testing to be done in the area. So that's something that I'm trying to work on right now to be done sometime coming up.
Mm-hmm. I believe for the first time in a very long time, I saw a flyer for a free COVID testing event, and I'm not sure if that happened this week or if it's coming up. It was just a glimpse of the flyer. I couldn't find it. I was trying to find it for today, but
right.
You know, it was amazing to me because I was like, oh, there's another COVID testing because we hadn't seen it in so long.
Yeah. We haven't, and I got like I said earlier, I felt like that was going to happen as we got closer to the end of the summer, as school coming back. But I was in contact with they actually reached out to me, a source who that works with DHEC and some national entities to look at getting the test done and having the results turned around within 3 or 4 days. That was my biggest question about that, is how long is it going to take these tests to turn around? Because we've had some entities that have had these community tests, and it took over a month to get the results back. So so that's my biggest concern about the community test, is making sure that we get these back in a reasonable amount of time. Mm-hmm. So that way contact tracing can be implemented in an effective manner.
Mm-hmm. Well, you know, I certainly hope that you know, that's going to be the case as far as being able to get the testing back and going in a very robust way. Because I mean, those numbers are certainly going to impact a lot of things that are happening right now. You know, we're still at a medium risk level with our school districts, and so students are in the hybrid, you know, school mode as far as returning to school, and you know, some are even venturing to go back and get out of the total virtual mode and go, you know, to the face-to-face environment. And so I think it's important for us to get these numbers just to make sure that the decisions that are being made are the right decisions for our students, not only from the standpoint of the school district, but the parents need to understand that, you know, COVID is still very real. We know that it's still affecting people. I mean, in the past 24 hours, we've had the biggest, most, I guess, most famous case at this point, which is the President of the United States has tested positive for COVID-19. Along with the First Lady. So yes, it is very much a real thing still in the United States.
Right. And hopefully some of the people who weren't buying into the fact of getting it, buying into the fact that it wasn't real, will now start to look at it differently, and we'll wear these masks. Mm-hmm. Again, I mean, this was bound to happen. I mean, you know, I'm a physician, so I don't want anything bad to happen to anybody. Mm-hmm. But certainly, this is no surprise to me that he tested positive. Mm-hmm. And so again, hopefully he'll recover. And you know, again, that's the physician side of me saying that.
Of course, of course. And there were other reports that Vice President Biden and his wife tested negative for COVID. And, of course, it was very alarming to hear the news that the president tested positive, considering the fact that, they just had the debate the other night. He was, definitely on a live debate stage. And then I think, even days leading up to that, was around a lot of different types of people and a lot of different venues walking around, with positive COVID happening and not knowing it, not being aware of it. So
all those people should be tested.
Yes.
And all those people should be in quarantine.
Mm-hmm.
And that's just, that's the recommendations.
Mm-hmm.
And so again, hopefully that will happen. And, and hopefully those people will be fine.
Mm-hmm. One question that comes to mind as you were just saying that, even though Vice President Biden and his wife tested negative, just as a precaution, should they go into quarantine?
Well, again, the rule of thumb kind of is closer than 6 feet for more than 15 minutes. So in that situation, probably more of a test in that situation, because they weren't really close. If they would have gotten close, they probably would have thrown punches. But definitely testing. Definitely testing. But everybody that was on Air Force One, all those people need to go into protective mode, isolation, quarantine, so that way they and get tested. Yeah.
Okay. All right. Well, we've had changes in the weather in the past couple of weeks as well, Dr. Mack, and it's we've had a string of really cool mornings that I have totally enjoyed, and and then a couple of warmer days popped up, and typically people are susceptible to colds and things like that when their bodies are trying to adjust. And so as we go, like you said, as we go into the cold and flu season, I guess people just need to really be mindful and try to distinguish between feelings of just change in the weather and maybe a little sniffle versus thinking that you may have COVID. And so how can people be mindful of that, or at least distinguish between the two? What would be some of the more pronounced symptoms if they have COVID?
Well, chronic cough, fevers, because again, and let me say this before I answer that question, you can have more than one infection. So you can have bronchitis and COVID. You can have pneumonia and COVID. So again, they're not mutually exclusive. They can coexist together. And quite often with the sicker folks with COVID, they actually have pneumonia in a lot of cases as well. So again, that's important to stand up with your shots. The flu shot's very important. Again, as I said before, you cannot get the flu from the flu shot. Okay. The flu shot is a killed vaccine. It is particles of the vaccine. Your body mounts an immune system to those particles. Hence, you have resistance and immunity and parts of your body, your immune system ready to fight off if you actually see the actual flu vaccine. Now, will you get a little achy? Probably. Will you sometimes feel like you're getting sick? Probably. But that's not a bad thing. That just means that your immune system is getting ready to mount a response so that if you do see it, you'll be ready to fight it off. The pneumonia shot is very important to make sure that you get that. Shingles shot. There's shingles vaccine. If you've ever had chickenpox before, you would be, or been exposed to chickenpox, you would be susceptible to getting shingles, which is a reoccurrence of the chickenpox varicella virus, which attaches to a nerve and it follows that nerve, creating a significant amount of pain. Depending on where it's located can be what problems you have. I've had 3 patients go blind with shingles because they've had shingles in the eye.
Oh my goodness.
So, so depending on where shingles is located, it can do some major damage. An extension of shingles where it just stays on and persists on is called post-herpetic neuralgia, where that nerve is just chronically irritated with chronic pain.
Okay.
All those things are real.
Right. And real quick, regarding the flu shot and the pneumonia shot, should there be a bit of separation between the two, or do they typically administer those shots at the same time if you
It
go to
depends on the pharmacy. I mean, a lot of times they will give it together. Now pharmacies are actually kind of leading the pack in giving these vaccines. Part of it is a financial thing. A lot of these manufacturers will not take these vaccines back if they're unused. So, for a physician to buy, a pneumonia vaccine or a shingles vaccine, you have to buy it in a lot of like 10 or 20. So if you don't use it, you just lose that money.
Right.
Whereas they will take them back from pharmacies. So, some physicians kind of had a little worry about pharmacies giving the vaccines. To me, I don't care. They're licensed to give them. They're certified to give them. So as long as that's the case, then I'm okay with it.
Okay.
But the most important thing to me is that the people get the vaccines.
Okay. All right. So, of course, I think you've answered JD's question. He wanted you to talk a little bit about the importance of the flu shot. And, last year, I don't know if it's sad to say or not, but last year was the first time that I had gotten the flu shot, and I decided to get it because my mother, God rest her soul, was she was not ill, but I did not want to expose her to anything. And I didn't want to run the risk of getting the flu or anything and having it affect her. And you're right, there was a little bit of achiness, a couple of days. And then after that, I was good. But it was just a great time to lay down and get some rest, really, after getting the shot. And I will get that again this year. So, and then, of course, just kind of speaking on, what we're going to see in terms of people adjusting how they behave or handle COVID and the information that's coming out. Ms. McIver has brought the point that she heard that the school district is considering distancing 3 feet and not 6 feet because there are more students coming into the face-to-face environment. Right. What are the implications for that, Dr. Mack? I mean,
well, the implications is that they're going to be a higher chance of people getting infected. What a lot of this science is kind of hoping for is that once you get exposed to it, that you'll have antibodies that will reduce the chances of you getting it again. And that's a controversial topic because, as I said, probably about a month, maybe a month and a half ago, there were some studies that were shown that there was a rapidly decaying antibody. In other words, when you come in contact with, let's say, COVID in this case, your body should produce antibodies to fight COVID off. Okay, those antibodies, in theory, would be protective to help reduce the chances of you getting COVID again. However, there were some studies that were done that showed that in a matter of weeks, in some of these people, weeks to months, a person that had antibodies, the antibodies went away. So again, there's still more research that needs to be done on that, but there's some concern that everybody may not be exposed, may not have prolonged antibodies like we once thought they would. The term is called rapidly decaying antibodies. And so again, there's more research and more studies being done on that. However, as these kids go back, 6 feet will be less and less likely to achieve.
Yeah, it absolutely will. I know I was talking to someone who's in the school system, and I believe she said that in her class, she has 9 students, but in another classroom, it's as many as 16 or so. And I mean, when we think back on how those classes are stacked up, you're right. It's going to be impossible for them to maintain 6 feet.
Yeah.
It's just logic. I mean, it's just mathematics. You can't do that logically.
Especially in elementary school.
Especially elementary school.
Especially in these school districts where they already had crowding issues in the beginning. Yeah.
Yeah, absolutely. Well, Dr. Mack, that was, of course, another great COVID-19 update and a little bit of a discussion about the impact. And so, of course, we do have a special guest today to talk about, her experience. Excuse me. This is October. It is Breast Cancer Awareness Month. And again, we've got a little series going on starting today. It's called Yes, I'm a Survivor. And we'll be talking with a few people who want to share their stories and to give us an idea of what it was like to deal with breast cancer, and how they overcame, and what they're doing now to just maintain and sustain. And there's going to be some very heartwarming stories, I'm sure, but also it should motivate a lot of us to go and get checked, just basically get checked. So before we actually get into our special guest, I know Dr. Mack has some information that he wants to share about breast cancer, but she may want to be on this part of the conversation, so I'm gonna bring her in. Is that okay?
Yes, sure.
All right. So our special guest today, ladies and gentlemen, is Ms. Ty Grissett, Ty Davis Grissett. How are you doing?
I am wonderfully blessed. How are you?
Yeah.
All right. Thank you so much for joining us, Ty.
Now I have to give a disclaimer. This lady is one of my favorite people. She's a mover, she's a shaker, and she's about the business. So when April mentioned you, I said, certainly, sure, fine, great, thumbs up.
Thank you.
Yes.
I'll pay your $1 later.
Oh, Lord. Good stuff. So, we're talking about breast cancer. We're talking about over 3 million women in the United States living with breast cancer. Some are breast cancer free. Others are living and being treated for breast cancer currently. Upwards of 40,000 deaths per year, upwards of 250, 260,000 diagnoses a year. Now, although the majority of these cases and deaths are in women, it's not just limited to women. In 2020, it's estimated that about 2,600 men will get diagnosed with breast cancer, and a little over 500 men will die in 2020 from breast cancer. So it's not just of women. I'm sorry. I think in my career, I probably have had 2 or 3 cases of men with breast cancer. So again, yeah. So it's definitely something that is important. And although since 1975, the 5-year breast cancer survival rate has improved significantly, there's still a gap between people of color and non-color in the diagnosis, especially in the late stages. So that's something that's very important that I'm sure Ty will talk about as well too. But early detection is so very important with this. I think I've got a couple slides here.
Yeah. Pull those up for you.
Yeah, we're talking about it. We want to talk about in terms of risk factors. And a lot of times the risk factors are kind of broken down into modifiable risk factors and non-modifiable. The non-modifiable risk factors, we're talking about family history. You can't change your family, or personal history. You can't change that fact if you have breast cancer. But in family history, a first degree relative is about 2 times more likely to get breast cancer than somebody that doesn't have a family history. And a person with more than one first degree relative is about 3 to 4 times higher. So again, very important to understand that if you've got a family history of breast cancer, that not only needs to be talked about in the family, but all those women and need to be checked, screened, and on heightened alert for that. Personal history. If you've got a personal history of breast cancer, you do have an increased risk of developing breast cancer again. So just making sure that we're staying on top of that. Those are non-modifiable risk factors. The modifiable risk factors include decreased activity level, obesity, weight gain, diets high in fat, alcohol, and tobacco. Those are modifiable risk factors that can help reduce the chances of breast cancer. Now, in this table that I had, we talked about it just briefly last week, but I want to put it back up again so we'll understand that. A major risk factor, no, the last one. No.
You want to go back to the table? You want to go back to this?
So okay. On this one, major risk factors would be a history of previous abnormal breast biopsy, where it says atypical hyperplasia. that does increase the risk because those cells can sometimes transition into breast cancer. Having the BRCA gene mutation, which is a genetic thing. Family history, like I said, of breast cancer, increasing age, and a major risk factor being a female. Other risk factors include early menarche, having cycles that begin before 12, or late menopause, cycles that end after 55. That is an estrogen-related thing, and that does increase the risk factors somewhat of that, as well as not having babies increases the risk factor, childbirth after 30, and as I said, alcohol and dietary fat intake. Protective factors: breast cancer, exercise, and first child being born before 30. Those appear to be protective factors in reducing the chances of breast cancer. Okay. Next slide. Kind of breakdown by age. If we for diagnosis, as we see, the majority of people that get diagnosed are going to be between 45 and 75. Just to kind of have an idea statistically, the percentage of cases, you're talking about upwards of what? That's what, about 70% there are in that age range from 45 to 75. So very important to know that. Next slide. Okay, next slide. This slide talks about incidence or the occurrence of breast cancer and the mortality or death related to breast cancer. As I said several weeks now, and statistically in medicine, when we talk about cases, we typically talk about it in terms of 100,000 people. So the incidence of breast cancer in the far left is non-Hispanic white. It's 130, around 131 per 100,000, but the number of deaths is 20 per 100,000, as opposed to the second graph, which is non-Hispanic blacks, it's 126 per 100,000, but a higher statistical rate of deaths. Now, the thought behind that is that women of color probably are not getting diagnosed early enough and having more issues to deal with later in the progression of breast cancer. So although white women are being diagnosed more, it's because they're probably being detected more. Statistically, they're getting more mammograms done.
Gotcha.
So that will show the incidence. Of course, it'll be higher if you got more people getting it checked, but the treatment has a lot to do with the mortality. So if you're getting tested and getting found to have breast cancer earlier, your treatment can start earlier and you'll be able to have a better chance of a better outcome. Okay, and going on down, Asian Americans, Hispanic, and Asian Pacific Islanders. That's what the other three are. But again, focusing on the first two, that's a real statistic that's there, where the rate is much higher in African Americans, African American women, as opposed to any other group. Okay, next slide. Where it's being diagnosed in different stages. Local means that it hasn't really moved. It's right in one spot. You're able to take care of it right at that spot. Whereas regional, it may have gotten into the lymph nodes and gone just a little bit further. Distant, it's gone to some spread to some other organ in all likelihood. So what this really is a factor of the increase, there's a decrease in the number of deaths with breast cancer. And a lot of it has to do because more of the cancers are being found locally. So if it's found locally and it's not really spread, it has a significantly higher rate of being taken care of. We talked about this a little bit last week about 5-year survival rates. If 5-year survival rate for a localized cancer is about 99%, regional about 85%, distant about 27%. But again, that does depend on the size of the tumor as well. So there's a lot of other factors, but the long and short of it, and the take-home message is the earlier this is found, the more likely the outcome will be a positive outcome.
Dr. Mack, where are the lymph nodes located in your body?
You have lymph nodes throughout the body. And they basically, the lymph system runs right by
Ty's demonstrating for us,
arteries and nerves. And so what it does is that it basically filter out things that are not supposed to be in the arteries or the veins.
Okay.
But lymph nodes are actually, different places. Typically, most common ones in the armpit, underneath the jaw, different. We call them glands, but they're basically pretty much lymph nodes.
Okay.
Yeah.
All right.
Okay. Next slide. Okay. This is the mortality for deaths with breast cancer. And as we see, the numbers are going down in non-Hispanic Blacks, non-Hispanic whites, but it is still higher in non-Hispanic Blacks. So again, early detection will save lives. Early detection will lead to a better outcome. I just wanted to show this graph where the numbers are going down, and that's because early detection and people like Ty who go out and really advocate checking, getting your breast checked and mammograms and things like that, which is very, very important on an educational level to have these things checked. Okay, next slide. Okay.
So, of course, again, it's October, it's Breast Cancer Awareness Month, and Dr. Mack has kind of given us definitely some foundational information about why it's so important for everyone, and that means males and females, to go through the process of being checked. And one of the interesting things that Dr. Mack was able to find and share with us today are some images of breast cancer. So Dr. Mack, if you'll go into that in just a little bit.
So, right in here is arrows that are pointing to an actual breast tumor, okay, a breast cancer. This is a large tumor here. And so this actually is what a mammogram imaging study would look like when a person does a mammogram to see if there's any kind of masses or densities in the breast. This is certainly cancer in this case. It is large. Usually the cancers will have more of an irregular border. This is somewhat irregular and jagged. A lot of times they're more irregular and jagged, but this certainly would be highly suspicious off the bat for breast cancer. Okay.
All right.
So just to kind of give you a photographic look of what a cancer would look like.
So if this type of mass is detected in the breast, what is the next step?
Biopsy.
And that means going in and removing that mass, or what does it mean?
Usually going and get a sample
of it?
size of it. But this one being this big, they would likely go in and try to take the whole thing out.
Okay.
Yeah. Okay, now what this one is, it just kind of shows the advances in breast cancer imaging. So the one to the left is a 2D mammogram. That's the old mammogram that, had been done for years and years and years. But as technology advances, things get better. And so in here, this is the same breast, but what it is, it's a 3D mammogram versus a 2D mammogram. And I know it may look fuzzy and ghost-like for people that aren't
trained to know what they're looking at.
But this is a big difference. This is a big difference. Person, like me who reads mammograms, who reads x-ray, this is a huge difference in the quality of what you can see versus what you couldn't. This mammogram on the right is a 3D mammogram. It is found a cancer there. You can't see that as easily on the one to the left. The one to the left could probably miss this or just say it's fibrous tissue, but that's the difference there. Same breast, two different techniques, one 2D, one 3D. Just to kind of give you an idea of how technology is advanced. But, on this one to the left, I could look at it and say, maybe I see a little something there. But the one on the right, without a doubt, there's something there.
And the advances in breast imaging, how recent have these advances actually come into? In
the past 15 years, 10, 15 years specifically. There are lots of places around here now that have 3D imaging. Some people still doing 2D imaging, but a lot of places do have the 3D imaging now. And I would highly suggest you getting a 3D mammogram.
Yeah, that's what I had, the 3D,
right.
and I still show what the machine looks like. Exactly.
Right.
Mm-hmm.
Right.
Yeah.
And so again, like I said, reading mammograms, the one on the right, I'd say, I mean, on the left, I say, that looks like a little something there, maybe. And at that point in time, you would do an ultrasound off the bat. So in other words, it's usually mammogram, and if there's any question, ultrasound.
Ultrasound. Okay.
Whereas on the one to the right, there's definitely something there, and that would skip the ultrasound step and go right to biopsy in most cases.
Okay.
And the reason that's important is if you got to get an ultrasound, they may not be able to do it that same day. It may be 2 weeks before they can get it.
Mm.
So, that time plays a factor here when you're talking about this, because if you're not getting the mammogram done every year, you don't know when this developed. And that's the other reason why yearly mammograms are so important. So the radiologist can look at it and be able to compare one year to the next.
Okay.
Okay.
Yeah. So, Ty, before we actually go into your story, let's give our viewers a little bit more idea of who you are actually and what you do in the community, aside from just being an amazing breast cancer survivor. So, tell everybody a little bit about yourself.
Well, you are funny. You and Dr. Mack are funny. Currently, I am working as a consultant, and I'm doing a lot of consulting work with different organizations that want to partner with nonprofits. And I love to just truly go out and talk to people about health education and awareness. And probably for about 7 years, from starting back in 2007 up to about 2014, I was a volunteer for Susan G. Komen, Low Country. And I went around and did a lot of workshops about the awareness of breast cancer education and making sure that women knew the importance of getting their mammograms. So we did a lot of education about self-breast exams, teaching women how to make sure to feel correctly and the correct way to do the self-breast exams. And I did that for years. And it was probably one of my biggest shocks of my life when I was diagnosed with breast cancer.
And so that moment that I don't know if you got it by letter or they called you and told you to come in or what, but at the moment that
June 18th at 10:18 a.m. in the morning, I received.
You don't remember the details, do you? You don't.
I remember everything about it.
I know you do.
I knew the young lady that was that had to tell me that I was positive for cancer, and because she and I went to school together. When you go, these circles aren't but so big, and so I knew the tech, I knew everybody up there, and I could tell something was wrong because by the time from when I came in and it was jolly, from the time that I left, people were on eggshells. And so I knew something was up about my mammogram, but I had no idea what it was. Looking at that picture that Dr. Mack has of the mammogram is pretty interesting to me because when I was shown my mammogram, the radiologist on during my biopsy, he asked me to come into the room and actually look at my mammogram. And I said, yes, I would love to be able to see it, to see what everybody's talking about. And when I saw my mammogram, my first words were, oh my gosh, that's my mammogram. And he was like, yes. My mammogram looked very much like someone had put some paint on their finger and pricked it and had all these little dots all over it. My mammogram looked like it was just speckled with dots. And all of those speckles were little tumors. I had a very aggressive form of cancer. And just as Dr. Mack was stating, I had the wonderful ability to be able to look back at previous mammograms because I've had always obtained my mammograms at the same location. So they were easily able to look back for reference at the previous year's mammograms to make sure that this was not an anomaly, that this was something maybe that was truly different this time around. They were definitely able to see that because they had all of my mammograms all pulled up, all of it side by side so they could do a comparison. And that recent one, I was like, oh my gosh, what in the world? They were like, yeah, something's not right there. You're going to have some additional studies done. So And that's kind of what I went into. And
Right.
I was diagnosed in June, and I was in treatment by August.
Yeah, right away, pretty much, if you think about it.
And the only reason it took that long is because the insurance company wanted to fight.
Right.
That's another segment.
Yeah. And so again, that is so important. Just like, men with prostate cancer, it's so important to get those studies done annually, so that way the physicians will have a better idea of how long it's been there and when this started. That's very key, because in a lot of times that can determine, part of the treatment at least.
Absolutely. And more importantly, it gives the doctor a more holistic picture of you and your health versus just being able to look at that one different picture right there.
Exactly. Exactly.
I'm going to get this question here from Wendy Willis, who joins us every single week. She's a great friend of mine in the New York area, and she watches every week. And she wants to know, do we need a referral from a physician to go, or can you just make the appointment yourself? And I know that I can answer that, but I'd like for you all to answer that question.
In a lot of cases, a lot of these facilities now are saying you don't need one.
That's
the concern that physicians have with that, though, is to make sure that information gets sent back to the appropriate physician. That's the biggest concern that physicians have. There's a couple local hospitals now around here that are saying you don't need a physician's order. And part of that is because that hospital system wants to make sure that those patients are going to that hospital facility and not that physician sending them somewhere else.
Gotcha.
I always encourage to get an order, because if you get an order, it can be documented without a doubt where these results need to go to. So that's my personal bias as a physician on that. And it doesn't necessarily have to be a physician's visit even. Just call the office and say, look, I need to get a mammogram. Can I get an order? Sure, no problem. Let's get it. So that way it'll be documented who this person's physician is. Because if somebody puts it in wrong who the physician is, I'll give an example. A lot of medical record companies now, electronic medical record companies, actually have a third party that if a fax gets scanned in that office, if Jane Doe isn't, let me tell you this because this is actually a true story, actually. I had a patient who got a mammogram done. She went on her own and got it. She didn't get an order from me. She moved. So between the time she got the results and got the results sent back, she had moved. I didn't give her an order to get one. The lady had an abnormal mammogram. So they didn't have on record who the physician was to send the record to, and they couldn't get a hold of this lady because she moved. She just happened to come in for a visit and say, Dr. McIver, the strangest thing happened. I got a mammogram done, but I never got the results of it. I think it's okay. Okay, to me, no news is not good news with the mammogram.
The mammogram.
You know what that mammogram said. The mammogram was abnormal. She had breast cancer.
Oh, wow.
So the thing about not having an order really worries me, because having an order is another checks and balances to make sure that result goes back to that physician that ordered it. But the lady was like, I didn't even think about it. I moved. And so because I was mad about it and I didn't see, but again, the lady moved. And the address she gave them was not the address where she currently lived.
Oh, wow.
So to answer the question, you could probably get it at a hospital without an order. I recommend you get the order from a physician, and I recommend that you follow up on that to make sure. Because in this case, no news doesn't necessarily mean good news. Okay.
Yeah. Tamika Gore, who's listening in or watching actually from Charlotte, North Carolina. Thank you for watching, Tamika. She said she tried to make an appointment this weekend. It required a referral. So maybe, Doc, are they tightening up on that?
It depends on the hospital. I didn't want to call the hospital out that does that.
Right.
On the hospital.
Okay. All right. And there's another question for you, Ty. Did they say why it was not detected earlier since you had yearly exams?
someone is trying to call into my phone, and it's giving me troubles right now. Can you hear me?
I can hear you. Yes.
Okay, very good. I want to go back something really fast Dr. Mack said about the need for a referral for the provider. I'm going to speak up now as an outreach worker. So I'm putting my little outreach worker nurse hat on. I love the fact that it doesn't require a referral many times, because for many women, the fact that they do not have a primary care provider is an extra barrier for them in going and having the mammogram done in the first place. And for many women, sometimes they just need one excuse to be able to say why they couldn't have a mammogram. So the fact that, I need a referral, okay, I couldn't get it. Well, that's a convenient excuse that many of them use to be able to not have a mammogram. And for me, it's just like, because some people just need one excuse to get out of something.
Right.
I do hear what you're saying, and you make an excellent point.
If this is
out, when I'm working with barriers, a lot of times it's nice to not have to have the actual referral.
And I'm okay with that as long as they follow up on it and they're not of the opinion that no news is good news.
Right.
I understand both sides of it. Say it one more time.
She said you're right. Yeah.
Now, I understand both sides of it. But that story, had that lady not come in to see me, she might not be alive right now.
Yes, yeah.
And so that's my issue with that. But as long as it's follow up on it, and that kind of thing, then certainly access is key. Access is very important. So, and you're absolutely right. As long as they're following up on it, because this has been over 5 years. So if this had not been caught that way and she didn't come in, she might not be alive.
Well, God knows what's best, and I'm so glad you were able to pick up on that and catch that before it truly became something much worse. Could you repeat to me the question again? I'm so sorry. I'm sitting here trying to remember.
Yeah, the question was asked, did they say why it was not detected earlier since you had yearly exams?
I'm having trouble hearing you.
Why wasn't your breast cancer detected earlier? Did they say why it wasn't detected earlier?
Good. My breast cancer wasn't detected earlier because it was just that fast growing, that aggressive. When I was diagnosed in stage 1. I was actually diagnosed in stage 0, meaning that it was still intact. It was still within the milk ducts itself. It had not moved at all from inside the milk ducts. That was when I was diagnosed in June. By the time I went to surgery in August, I went from being stage 0 to stage 1. The tumor had already started growing and expanding. And my doctor said if I had waited another 4 to 5 months, I would have been about a stage 3 by the time I would have went in there. So it was not detected earlier because it wasn't there. But by the time it was there, it was such an aggressive, fast-growing tumor that it was really taking over, trying to really kill me and take me out. I can say from a month and a half, it went from stage 0 to stage 1.
Amazing.
So that's why. That's the importance of making sure that you get your timely mammograms so that you can make sure that you can watch for any changes that may occur. I couldn't feel any tumors. They were the size of a pin, pinprick.
I was going to ask you if you had any kind of,
I couldn't feel that.
Okay.
So there's no, breast exam that's going to help for that. It was a mammogram that was able to detect it. That's why it's so important to get your mammograms and not depend on just what you can feel. Because by the time I would have felt it, it would have probably been something about pea size, which would have truly have grown to be something much more of a problem for me than what I currently have now.
Right. And one of the best feelings, having scrubbed in on breast cancer surgeries before, is if you see an intact tumor and it looks like it's not gotten outside of the shell. I mean, you like, let's get it out. If you look like you've got areas all over, you're like, oh my God, we're gonna have some problems here. So that's why early detection is so important, because the tumor can be taken out in whole, intact, and then other adjuvant treatment can then be instituted, whether it be tablets, tamoxifen, whether it be whatever else you'd have used.
Absolutely. I want to make one more point too about something you said earlier, Dr. McIver, about the fact that African American women are more susceptible to mortality from breast cancer than pretty much any other race. And from my experiences in working with breast cancer patients, I have truly observed a couple of things. You're right in that a lot of African American women are detected at later times than the Caucasian or Hispanic women. We drag feet. If we have to go choose between paying a light bill or going to the doctor visit, guess what? Most Black women are going to choose the light bill because they feel like that impacts more people. So they're not going to take time for themselves. So many times, by the time you do go into the doctor's office, it's at a later stage where your mortality rates are quickly decreasing because you've waited a long time. The other thing too that I've noticed is that there are different types of breast cancer. I think we need to clarify that as well, so that people don't think it's just one breast cancer. No, breast cancer is like the big umbrella, and there's lots of different types of breast cancer underneath that. Out of the different types of breast cancer, it appears that African American women are more susceptible to having the deadlier versions of breast cancer. In particular, there's this one version called triple negative. And that means that you do not have 3 of the main markers for breast cancer. And that's estrogen, progesterone, and Herceptin. And her HER2 cells, excuse me. And out of those 3 things, if you don't have those, then you're really in trouble with about 75% of the medicines working effectively for you to treat breast cancer. Why is that? Because breast cancer now truly has become so advanced that many of the therapies now are targeted for certain cells and for certain hormones. And so many African American women, though, do not test positive for these hormones and these receptors, meaning many Black women don't have the genes that are needed for the targeted therapies. We just don't have those genes.
It's just genetic.
A lot of White people necessarily would have them, but a lot of the Black women don't. So then the targeted therapies, which are phenomenal at saving lives, don't work on us.
They're not effective on us. Okay.
Right.
That's right. And so that's why more Black people, this is a whole nother thing right here, need to participate in trials, because we need to try to make sure that we can find more medicines that are effective in working for us. But that's one of the biggest issues too. I am not a triple negative, I'm a double negative. I did have I don't have any hormone cells, but I do have a HER2 cell positive. So I take Herceptin. And my doctor, when I was diagnosed, he said the fact that you are HER2 positive, he said it saved your life. He said if you were a triple negative, he said I would have to give you much lower rates of being able to be alive in 5 years. He said, but the fact that you are HER2 positive, he said, I can assure you, you'll be alive. It's a 99% chance you'll still be here in 5 years.
Right. And as I said, because it's the localized, caught early, 99% localized. And that's right. And you're absolutely right in that those triple negatives, because if you add on a triple negative being caught later in the stage, later, then you're really in trouble. So that's the reason why it's so important for early detection, screening often and early detection.
Right. I have a classmate that was diagnosed with breast cancer probably about 3 months before I was. And this particular classmate was buried 2 weeks ago.
My goodness.
This classmate, she was a triple negative. And I remember when I was first diagnosed, she was one of the first people to really reach out to me and to call and talk with me and encourage me. And on the phone with her, I noticed that she was extremely depressed and extremely in a low place. And she said, I don't understand why you are so happy. And I said, because I know I'm going to live and I'm going to be just fine. She said, I don't think I'm going to live. And I just immediately felt my heart drop. She said, my grandmother died from breast cancer. My mother died from breast cancer. Her sisters have died from breast cancer. 2 of my sisters have died from breast cancer. So when I felt the lump in my breast, I didn't even do anything about it until it got to the point where it was starting to bother me so bad. And by then, I was diagnosed with stage 4 breast cancer.
My goodness.
And she died 2 weeks ago. And it breaks my heart because, in my opinion, she did not have to die. She did not have to die. So your mind has a lot to do with your survival as well.
That's
you
true.
You have to want to fight, and you have to want to survive. Because chemo is not easy. Radiation is not easy. It's not easy at all. And even though we talk about these targeted therapies, guess what? They are still harsh on the body. They're still pretty rough. Yeah. So there's times when I sat in that chair and I said, I've got to get through this because I've got 2 girls depending on me.
Right.
I have not an option. There's not a plan B. This is it for me. And you have to think positive while you're going through.
Exactly. There's 2 things I want to touch on. One, you talked about the participating in the trials. I think that a lot of times people are just skeptical and they don't trust where these trials are coming from or who's created the trials. And so, Dr. Mack, how can people be more assured of, a trial that's offered to them? What can they do as far as research to make them feel more comfortable with the idea of doing a trial test or trial, medical procedure or whatever is being offered to them?
Well, number one, looking at the source of who's funding the trial always plays a part into it.
That's right.
Number 2, who's attached themselves to the trial? Is this somebody that has a history of being well versed on this information? And you can always look at information around the trial to kind of get some pointed information about what it's looking at. The concern is that there's a lot of skepticism about trials, but again, that's that, and this is probably one of the cancers that trials for people of color is so important. And it's because most of these treatments are targeted for one of these 3 receptors. And if you're receptor negative on all 3 of them, that's still years of work that needs to be done by these companies to find treatments for those triple negative folks.
That's right.
And so it's very important. It's just very important.
Very important. So, doing the research, you've given a couple of pointers on what they can do to just make sure they're not getting something that is not from a reputable source or that hasn't been, validated or verified as a valid clinical test or whatever. And then the other part, Ty, you kind of touched on it, talking about, now what does this look like for your family's medical history in terms of the fact that you were diagnosed with breast cancer, and you just mentioned that you have 2 daughters? Are they going to be more susceptible to it? And of course, they will have to be as cautious as we are as women to make sure they're tested, or, is it generational, or, what are you going to do with this information in terms of helping your daughters to understand how it could impact their lives?
Well, first off, thank you so much for asking that question, because it's so important. One of the first things that was done after I was diagnosed with breast cancer is that I was introduced to a geneticist. And the geneticist then went and performed some genetic testing on me, including looking for the BRCA1 and BRCA2 genes to see if I was going to test positive for carrying those genes. Because if I did test positive for carrying those genes, then my daughters would need to be tested, and also my sisters and my mother would also need to be tested. Okay. There's no one in my family with breast cancer. I'm numero uno. So it was very much we've got to figure out how did this happen. And I came back negative for all genetic markers. That was actually good news for my daughters, because they were very concerned about, if mama's got breast cancer, are we going to have breast cancer one day? And I told them, I said, it's up to God really at this particular point, but you don't have any markers. I didn't have any markers either. Didn't stop me. So that means then you have to work on your modifiable risk factors, as Dr. McIver was saying, to make sure that you lower your risk for breast cancer itself. The other thing to think about too that's really important is also making sure that for other people, look at your family history. Make sure that you have those conversations. But when you're at your family reunions, make it part of your business also to find out what do people die from, so that you could be up on what you need to be looking out for. Because one of the things he did talk about was the fact that many of these diseases many times run in families. I told the story about my friend, her grandmother, mother, sisters, aunts, all of them had breast cancer. Her number one thing should have been, how do I not get breast cancer?
Right.
She should have been on top of that from day one once she found out, including if she needed to have a double mastectomy at an early age, just to lower her risk for it as well. At least that's the way that I think about it. Everybody thinks about it a little bit differently. But Grandma always said, when you know better, you do better.
That's right.
This is one time
supposedly. Exactly. Right. Denise Chapman has a question about the mobile mammogram unit, and I think that's hey Denise, thank you for watching from Georgetown.
Medical Center. I was just up there yesterday speaking to them. It is certainly available. They like to bring it out at events, but they do like to make sure that when you bring it out, that you can kind of guarantee some people are going to be out there to be tested. It's expensive to bring out mobile mammography. So they want to make sure that they can utilize the services versus just kind of sit there. But also MUSC has mobile mammography. I've utilized them before as well. And also McLeod Health.
McLeod does
too, that you can utilize. Go ahead, Dr. McIver.
No, I was about to say McLeod.
Yeah, he was saying McLeod. Yeah. Yeah. And I would even encourage people if who are working in corporate settings or any institutions or companies to encourage their HR directors or the owners of these businesses to be in touch with these hospital systems to see about setting up these types of events on their premises, because if the it's mobile, it can come to your business, and that will also help to guarantee that there will be enough people to actually take part in the testing. I know I work for Georgetown Technical College, and they have McLeod unit. It comes out from time to time, and it's very convenient as well for people if they want to or need to have a mammogram, but they just can't find the time or whatever to go and make it happen. And then too, when it's in your face, there's no excuse. It's coming to you. So, that's one good way to, just to, even get your company involved in the process. And, again, there were some comments about the insurance and all of that. And I know that that's another topic or whatever altogether. But, I know that in my experience, luckily I do have insurance that covers it, or that covers some of it, or whatever the case is. But, what can people do who do not have insurance, or they're underinsured? What can they do?
Well, thank you again for asking that one. That's such an important question. Two things. Never let the fact that you don't have insurance stop you from pursuing quality health care. There are programs out there to assist you. You just may have to do some searching for them, but they're out there. Mammograms are probably one of the easiest things to get done if you don't have any type of insurance. Probably easier if you don't have any type of insurance, because there's different grants that are available for them. In particular, there's also the Best Chance Network.
Best Chance Network
will provide free mammograms and also free pap smears for low-income women ages 40 through 64 years of age. They have to meet some income guidelines, but it's called the Best Chance Network. Put that in your Google browser and be able to look for the closest provider for you in your county. They are all across the county, and they're traditionally located at the FQHCs, which are probably like your free medical clinics, your Little River Medical Centers, your care team, your healthcare partners, St. James Santee, and Hope Health. I think I've covered all the ones in our Broward County area. If you'll look at some of those, but there's also different private providers that also are able to offer free mammograms through that.
Right.
Foley Medical Center also has a very interesting and wonderful partnership with Tanger Outlets. Tanger Outlets collects funds during the month of October, which those funds are then utilized to help low-income women receive their mammograms. So for women that don't qualify for Best Chance and don't have private insurance, to make sure that they don't fall through the cracks, they're able to receive funding from Conway Medical Center through Tanger Outlets program, Mammography Initiative, to make sure that no woman falls through the cracks that needs a mammogram.
Right.
Oh, that's awesome.
Those are good.
Great program. I've actually just partnered with them to encourage more women to get their mammograms at Tanger Outlets. So it's been a great thing.
Right. And even for people that are out of the area that are watching this, just calling the local hospital to see when they're having any kind of community screening program that's going on can also help too.
That's right. And you mentioned also, it's not just our Tanger outlet, it is all of the Tanger outlets across the United States.
That's awesome.
They each have a local initiative that they work with to provide mammograms, free mammograms for low-income women. So it's not just our Tanger outlets, for those all across the United States. Call that Tanger outlet office and they can guide you towards the correct one you need to go through.
Go shopping and get a mammogram. I tell you.
It's really a nice program.
That's awesome.
I think last year the check was over 50,000. I'll just put it there.
That's awesome. That's absolutely awesome.
Yeah, it's given a diagnosis of any kind of cancer, but especially prostate or breast, that's a far advanced cancer, has always been tough for me to do because in a lot of cases, these things could be 100% preventable, treatable, and preventable. So again, just making sure early detection, making sure you stand on top of things, and make sure that you're adamant about it. It's so important. But the treatment has gotten a lot better. Still got a lot of work to do on the triple negative, though. But again, in that case, it's very important to get detected early.
And I would like to also add in there is that we as people just need to put ourselves first. So many times we will put other people ahead of us. We'll put other needs and other desires ahead of us. But at the end of the day, if you aren't taking care of yourself, who is? You need to make sure that you're able to do the things that you need to do, and you've got to be healthy and alive to do that.
Right.
So make sure you get your annual screenings. I love when you said earlier about men need to get their prostate also checked. They need to know those PSA levels. Prostate cancer is a terrible killer here of African American males in South Carolina. So we truly need to be working on those numbers to get those lower as well. And there's all the other different cancers too. It's not just breast cancer. There's lots of other different cancers. Right. Truly, with colon cancer, with the actor, and making sure that we can truly bring about awareness to all the different types of cancers that are really just taking people out early and at a younger age. It's not just an older person's disease. My doctors repeatedly have told me I was young to be diagnosed with breast cancer at 45. So it's just something to think about. I never would have thought about breast cancer right now, thinking about raising kids.
Exactly.
But when it comes into your life, it certainly takes the front seat.
Right.
Exactly. Ty, if you will, and I don't know if you have it handy or how long it would take you to pull it together, but if you will pull together a list of those resources for the uninsured or the underinsured, I'll be sure to post it to the network and to our connected or affiliate websites. And so that people will have that information, and we'll also share it on the Whittemore Community Magazine, and we'll definitely do that. And there was one other thing that I wanted to touch upon. Maybe it'll come back to me in a minute, but this is absolutely great information. And I just wanted to let everybody know, Councilman Orton Bellamy, Horry County Councilman, he posted that there's a breast cancer walk Saturday, October 17th from 8 a.m. to 10 a.m. It's going to be at Bethel AME Church. And Bethel is located at 1530 Race Path Avenue in Conway, right off of Highway 501, pretty easy to find. That is for everyone in the community, not just, for the African-American community, but everyone come out and be a part of that breast cancer walk. So I wanted to bring some special attention to that as well. And then there's a question that has come up about the insurance. And I don't know if you guys know anything, but, why is it that insurance won't pay for a 3D mammogram? Is it that insurance won't pay for it, or is it just limited?
It depends on the insurance. It depends on the plan.
Yeah.
Of course, 3Ds are going to be more expensive than 2Ds because you're paying for the technology. So that's an individual specific insurance thing.
Mm.
It has to do with
I would say, don't let that stop you from getting a mammogram just because it won't pay for a 3D. You need a mammogram. It's a bonus if it's a 3D, but you need a mammogram.
Exactly.
Absolutely. So I have there's a couple of things that I want to bring to our attention. And then I know you had an infographic that I'm sure you want to share before we end this broadcast. But I want to make everyone aware that, of course, as I mentioned at the top of the show, one of our destinations for this live stream, when I say destinations, I mean internet destinations for this live stream, is the Emmanuel 9 Memorial Foundation. And of course, Dr. McIver has a personal connection to the Emmanuel 9, and that his aunt was one of the victims of that horrific event down in Charleston. And so their Facebook page serves as our streaming destination for this particular show. And they have an ongoing campaign that I would love for everyone to participate in. We'll post more information about this later, but it's called $17 on the 17th. And so basically, they would appreciate it if people would consider donating $17 to help build, and $17 on the 17th. You can do it anytime, but 17th is the campaign. To help build the memorial to honor the 9 lives lost on June 17th, 2015 at Mother Emanuel Church in Charleston. So to contribute, all you need to do is go to www.emmanuel9.org, and Emmanuel is spelled E-M-A-N-U-E-L. So 1 M, emmanuel9.org to donate. So if you will do that, that would be most helpful. The Emmanuel 9 Memorial encourages people to reconcile their hearts and actions with the example of love set by the families of the Emmanuel 9. And the memorial will also honor their lives by teaching new attitudes and behaviors to end racism. So again, if you're looking for a cause to support, certainly reach out to the Emmanuel 9 Foundation and support them on the 17th of each month with your $17 donation to help complete this memorial. So thank you so much for submitting that information, Jamila Gatz, and I really do appreciate it. And again, appreciate this connection of the network to the Emmanuel 9 Foundation's Facebook page. So I wanted to make a mention of that. And then Ty, you want to go into the infographics real quick, because I have another big announcement, but I'm going to wait till the end of the show for that.
Do you want to do the infographic? You want me to just talk about it?
I can pull it up while you're talking about it. I'm sure it has some very important information that might just kind of, button up everything that you and Dr. Mack have talked about tonight. So why don't I just pull that up for you right now? And then, and what I did was I just kind of divided it into 2 pieces so that it would be easy for you to look at and also for our viewers to see.
Sure.
Okay.
Pretty much right here. This one is talking about 40 is an important number. Women should start getting their mammograms when they turn 40 years old, and 40 until. It doesn't necessarily have an end date. I always tell people, because I've seen a lot of older women in their 70s diagnosed with breast cancer. So you should just start when you're 40 and continue from there. I will also highlight, though, if you have a family member that was diagnosed maybe at like 43 or even 35, you need to start getting your mammogram earlier. You don't wait till you're 40 to have that mammogram. Look at your family history and then do a good judgment call on when you need to start making sure that you receive your mammogram. Here in Horry County, the youngest breast cancer survivor that I worked with, she was 13 when she was diagnosed.
Oh my
so
goodness.
Age again doesn't mean anything. This one also says right here that 1 in 6 women with breast cancer occurs in women ages 40 through 49. So that would be me. 1 in 6. So there's not a lot of young breast cancer survivors younger than 50, but guess what? It's enough of us that we make a statistic. The other one that's also in here I thought was very interesting is you see that number 70%, and that says a Harvard study showed that 70% of women who died from breast cancer were among the 20% not screened. So what does that mean? Out of the women that weren't screened at all, 70% of them were women that died. So that means essentially you wait to get screened, you're putting yourself at high risk from dying from breast cancer. Their breast cancers were diagnosed at a later stage. And this 1 in 69, 10-year risk for breast cancer in 40-year-olds is 1 in 69. So that means essentially that your risk for breast cancer truly increases as you get a little bit older. And the most important one, I think it's on the other one, is the 1 in 8. 1 in 8 women in their lifetime will be diagnosed with breast cancer. You went to the bottom. Oh, okay, let's see. Yeah.
Oh, you want me to go back to that one? Yeah, I can go back. No problem.
Yeah, go on to the other one.
Okay.
Yeah.
Okay.
1 in 8 women in their lifetime will be diagnosed with breast cancer. Go to the one that's got every 2 minutes. Do you see that one?
No, I don't see that one. This was yeah.
Okay, well, no worries.
Okay.
Every 2 minutes, a woman is diagnosed with breast cancer. So just imagine, since we've been on now a little over an hour. Every 2 minutes, that means 120 women since we've just been talking have been diagnosed with breast cancer. And every 13 minutes, a woman dies from breast cancer. So just then think about how many women, about 5 women have died from breast cancer since we've been talking. That's pretty prevalent. Breast cancer is the number 1 cancer in cancer. I don't want to call it cancer killer, but it's certainly the number 1 cause of death in women. And it's also, out of the 100 people diagnosed with breast cancer, 1 of them is a man. So I heard Dr. Mack was talking about earlier about how many men he's treated with breast cancer. I've known 3 in my lifetime here in Horry County that have been diagnosed with breast cancer. So don't think it's just a woman's issue. It's a man's issue as well. And one more thing to say about men, and then I'll close and pass the baton. Men, it's very important for you to be aware of breast cancer, because I've known many men that have detected the lump in their wife's breast. So I've met several men that it was them that detected the lump inside of their wife's breast and encouraged their wife to follow up and get additional screening and testing done on that. So men, this is one time that you can say the nurse told you that you need to go and feel and make sure everything is okay. This is the one time that I will give you the pass on that, is making sure that your wife is okay. Women, also make sure that you feel your husband. Make sure he doesn't have any lumps where they don't need to be. Absolutely.
Well, I tell you that this has been such an awesome session. And, you know, I've certainly learned a lot just sitting here, and feel even more encouraged and motivated to make sure that I'm getting my annual exams on time. And I hope that, you know, there are others who are watching. If you've never had a mammogram, please go out and do that. And you know, make sure that you make it a part of your regular health routine. I like what you said earlier, is that we have to learn how to take care of ourselves, because if we don't take care of ourselves, we certainly can't take care of anyone else. And, you know, and our health is everything. You know, try to function in the realm of a day with a migraine, even I mean, even something that's not so simple for people, but I'm saying even a headache can get you off your game. So imagine someone having to deal with something as chronic or as critical as breast cancer or any of the other kind of cancers that we're focusing on. And wanted to make that point as well from earlier. I think that's what escaped me earlier. Dr. Mack has also, he's going to devote time to covering different kinds of cancers each week. And that's what the part of the Medical Minute is going to be about. It's just kind of, you know, bringing awareness of the different cancers that exist. And so, you know, this is definitely going to be the place to be on Fridays at 4:00 for as long as we can do it Fridays at 4:00. And if we can't do it Fridays at 4, we're going to change the time and date. But basically, Dr. Mack has given us this information. It's preventive. It's proactive, not reactive information. And I thank you so much for sharing your story today and being here. And I know that you definitely are one to, educate us all the time. And so I want to, continue to encourage you to do that, to help everyone as much as you can, because you're not only saving your life, but you're saving our lives as well. So thank you so much, Ty.
Yes,
really do appreciate it.
Thank you. Appreciate it.
Yeah, really do appreciate it. And Orton Bellamy also asked, he says we can schedule COVID-19 testing in Conway. Do you have a location? So
tell him I'll talk to him.
Okay, Orton, Dr. Mack's going to get with you on that. See, this is how we network. This is how you make it happen. Okay. And then he says also we have access to 3D mobile mammography. So Dr. Mack, do your thing. And yes, and whatever I can do to help, please let me know. Then there's a special request, and we may have covered it before, but we can circle back around. But there's a request. Thank you, Stacy Phillips, for tuning in today. Colon cancer next, please, is what Stacy has said.
Yeah, we can go back and review.
Yeah, we can go back to that.
We actually did that one about 2 weeks ago, but we can go back on that.
Yeah, definitely go back on that. Maybe we just need to make a list and go ahead and create a schedule. And and if there's any of you who are watching and you have a story that you would like to share, much the same way that Ty has shared her story, remember, people tend to relate, and they are motivated and inspired to do things when they feel that, someone else out there understands what they're going through or has been through it. And you never know what lives you've shaped today, Ty, just by sharing your story and someone being curious enough to go and get tested. So, definitely let us know if there's anything that you've experienced that, we can create as a show topic, and we would love to bring that information to the public. Thank you so much, Angelia Robinson, for tuning in today. We really appreciate you, one of our educators in the area. And Stacy, you have not missed it. Well, you may have missed it live, but you can get the rebroadcast on Facebook, and it's also going to be on our YouTube page. And so I wanted to make a special announcement. I'm very, very excited about what I'm going to share tonight. But there's some information that I have for the network group. And so if you are a member of the network group, please make sure that you tune in tonight at 8 p.m. And then I'm going to make a special announcement there. And I'll be making a public announcement real soon about something that we're doing to elevate the network live and the group that has been put together to connect Black businesses to the community. So again, if you are a member of our network group, tune in tonight. You've probably already received your special event invitation, and that's 8 o'clock in the network group live, a special announcement. And I promise you, you'll be excited. You won't be sorry that you took the time to spend, just a few minutes with me. So for this special announcement. So again, Dr. Mack, thank you so much. And I think I put out the information about the breast cancer walk. Yeah, I put that out. At least I said it, and I'll make sure that it's posted on Facebook pages and Whittemore Community Magazine Network, and also on my page, because I know a lot of people tend to come to my page for information as well. But Ty, thank you so much.
Yes.
Really do appreciate having you here tonight.
Thank
yes,
you.
Love you too, sister. Always, yes. And Dr. Mack, and I couldn't do this without you. So thank you so much for all that good information.
We're doing it together.
Can I get my honorary white coat one day? Because I feel like
after you sit through all these talks,
I'm gonna be an expert on something. I can give you a little something, but the rest of you have to go to Dr. Mack to get it. But I can get you started. So maybe I won't have a white coat, maybe a beige coat or something like that, ivory or off-white coat.
We can work on it.
Okay, Dr. Mack, I appreciate you. But anyway, thank you all so much for tuning in. We really do appreciate it. And take care. Have a safe weekend. Remember, mask up, wash your hands, and thank you, Brittany Green, for tuning in. She just chimed in, great information. And I just want to say Brittany's actually going to come and share her story with us a little bit later on. This is actually next week. She'll be here to share the story. So stay tuned as well for that flyer and that information on our next guest, who will share her breast cancer survival story as well. So thank you all. Have a good night.
Okay.
Network members, see you at 8.
All right.
All right.